Good afternoon, all. Today's webinar is being given by Dr. Yamini. She is our consultant microbiologist, over 10 years of experience in the various sections of microbiology. She will be covering an interesting topic on infectious hepatitis today. So I hand over the session to Dr. Yamini ma'am to continue the session.
Infective hepatitis. Hepatitis is the inflammation of the liver. It is of two types: infectious, caused by bacterial, protozoal, fungal, and parasite. Viral, non-infectious, caused by chemicals, alcohol, drugs like acetaminophen, ketoconazole, methyl dopa, methotrexate. Bacteria causing bloodstream infections result in hepatic ischemia or acute hepatitis, usually caused by bacteria like Brucella, Leptospira, Yersinia pestis, Treponema pallidum, Mycobacterium tuberculosis. Severe sepsis lead to hepatic ischemia or acute hepatitis caused by Escherichia coli, Enterococcus fecalis, Klebsiella pneumoniae, hospital-acquired pathogens. Local inflammation leads to liver abscess caused by Streptococcus miliary, Escherichia coli, Streptococcus fecalis, Klebsiella pneumoniae, and Proteus vulgaris. Fungal infections can cause hepatitis like Candida, Aspergillus, Histoplasma, Cryptococcus, Blastomyces, and Coccidioides. The liver is crucially involved in various parasitic infections as well. Echinococcus species, liver flukes like Fasciola hepatica, Ascaris lumbricoides, Entamoeba histolytica, and Schistosoma. Viral, it is again divided into hepatotrophic viruses and non-hepatotrophic viruses. I will be dealing with in this session only with the hepatotrophic viruses, that is hepatitis A, B, C, D, and E. Non-hepatotrophic viruses causing hepatitis are cytomegalovirus, adenovirus, herpes virus 6, varicella zoster virus, and Epstein-Barr virus. Viral hepatitis, the mode of transmission are different. For hepatitis A and E, the mode of transmission is through fecal-oral route. It is highly contagious. They occur in outbreaks as well as sporadic and cause self-limited hepatitis only. Serum hepatitis is caused by hepatitis B, C, and D. Mode of infection is parenteral, sexual, or injectable drug abuse, and not only and they are not highly contagious. They occur sporadically and rarely may cause outbreaks. They may also lead into chronic infection, cirrhosis, and hepatocellular carcinoma. The course of acute hepatitis is highly variable. It may be transient, asymptomatic to severe or fulminant disease with complete resolution, or run a relapsing course and lead to chronic infection. Incubation period varies from 2 to 20 weeks. It is usually determined by the viral etiologic agent and as well exposure dose. During this phase, virus becomes detectable in blood, but serum aminotransferase and bilirubin levels are normal and antibody is not detected. During the peak tonic phase of illness, there will be non-specific symptoms such as fatigue, nausea, poor appetite, vague right upper quadrant pain. Virus-specific antibody first appears during this phase. The pre-icteric phase typically lasts 3 to 10 days but may be of longer duration. Viral titers generally are highest at this point, and serum aminotransferase levels start to increase. During icteric phase, the symptoms vary like dark urine, jaundice, fatigue and nausea, anorexia, dysgeusia, and weight loss. Physical examination usually shows jaundice and hepatic tenderness. Hepatomegaly and splenomegaly may be present. Serum bilirubin levels, total and direct, rise, and aminotransferase levels generally are higher than 10 times the upper limit of normal. Levels of hepatitis virus begin to decrease in serum and liver. The duration of clinical illness is variable. It typically lasts for 1 to 3 weeks. Recovery is first manifested by return of appetite and is accompanied by resolution of the serum bilirubin and aminotransferase elevations and clearance of virus. Neutralizing antibodies usually appear during the icteric phase and rise to high levels during convalescence. Complications of viral hepatitis include chronic infection, fulminant hepatic failure, relapsing or cholestatic hepatitis, and extrahepatic syndromes. Chronic hepatitis generally it is defined as illness of at least 6 months duration. It develops approximately 2 to 7% of adults with hepatitis B, 50 to 85% of adults with hepatitis C. Hepatitis B, C, and D infections are said to be chronic if viremia persists for more than 6 months. Hepatitis A viral infection. This infection incubation period is of 30 days. Virus can be found in feces for up to 2 weeks before becoming symptomatic. Illness subsides within 2 to 3 weeks but can recur. Recovery is usually complete within 3 months. It is a vaccine protective disease. First dose at 6 to 12 months of age, followed by a booster after 6 to 12 months. HIV viral particles can be detected in the stool, blood, and bile by electron microscopy before the elevation of the liver enzymes and before patient develops symptoms. HIV IgM becomes detectable after 1 to 2 weeks of infection and it indicates acute infection. HIV IgG develops after 1 to 2 weeks of IgM that indicates chronic infection. Many ELISA techniques are available for the detection of antibodies. Detection of only IgG indicates either it is recovery or past infection. Coming to HBV viral infection, here the incubation period is 30 to 180 days. More than 90% of infants that are infected will develop a chronic hepatitis B infection. Up to 50% of young children between 1 to 5 years who are infected will develop chronic hepatitis B. 5 to 10% of healthy adults 19 years and older who are infected will develop chronic hepatitis B. It is 90% will recover after an exposure. A small percentage can progress to a chronic state, serologically defined as the presence of hepatitis B surface antigen for greater than 6 months. It is a vaccine protective disease, first dose at birth, second dose after 1 month, followed by a booster after 6 months after the first dose. The lab diagnosis of HBV infection can be done by HBV DNA detection by PCR or the detection of serological markers of hepatitis B in various stages of hepatitis B viral infection using many rapid methods as well as ELISA techniques. There are different serological markers related to HBV. There are HBsAg, HBe, and hepatitis B surface antigen, hepatitis B envelope antigen, anti-HBs, anti-HBe, as well HBC core antigen, HBC, anti-HBC IgM, anti-HBC IgG. These are all they develop in the blood depending upon the course of the illness. Earliest antigen to develop is the hepatitis B surface antigen. It develops before clinical and biochemical evidence of the disease. So, along with HBsAg antigen, HBe as well as HBV DNA can also detect together along with HBs antigen. So, depending upon the development of the various serological markers, we can stage the disease. If only HBs antigen is detected in the serum, it indicates early acute hepatitis. With HBs antigen, if anti-HBC IgM and HBe antigen is detected, it stages acute hepatitis B. The patient is highly infective. HBe antigen is related with the infectivity and viral replication of the virus. And HBs antigen with HBC, IgG, and HBe antigen. It is related with the chronic hepatitis B and it is high infectivity. It is also called as supercarriers if they are asymptomatic and liver enzymes are normal. When HBsAg and anti-HBC IgG with anti-HBe is detected, it denotes chronic hepatitis B and the patient is low infective. They are called simple carriers if they are asymptomatic and normal liver enzymes. HBsAg with anti-HBc IgG indicates precore mutant hepatitis B. Anti-HBs with anti-HBc with presence or absence of anti-HBe indicates recovery. Anti-HBc IgG alone indicates remote infection, more common. It may also be due to false positive immunoassay, that is very rare. HBsAg with anti-HBs, anti-HBc IgG with or without HBe and anti-HBe indicates HBsAg of one subtype and heterotypic anti-HBs, common, seen in 10 to 20%. Or it may also indicate the process of seroconversion from HBsAg to anti-HBs, which is very rare. Presence of only anti-HBs antibody indicates post-vaccination. In presence of anti-HBc IgM with or without anti-HBe and HBe, it is a time period between the appearance of anti-HBs antibody and disappearance of HBsAg. This is the only antibody which can be detected between the disappearance of HBsAg and appearance of anti-HBs. HBC core antigen cannot be detected serologically as it is coated with HBs AG envelope, so it is non-secretory. It can be detected in the hepatocytes by immunofluorescence. There is one more condition called occult HBV infection where HBs AG is not detected in the serum but replicant competent HBV is present in the hepatitis D viral infection. Hepatitis D virus is known as a satellite virus because it can only infect people who are also infected by hepatitis B. The routes of HDV transmission is similar to HBV through broken skin via injection or tattooing, etc., or through contact with infected blood or blood products. Transmission from mother to child is possible but rare. Vaccination against HBV prevents HDV co-infection. HDV infection occurs as a co-infection or superinfection. Co-infection with HBV or superinfection in HBV carriers. HDV infection is diagnosed by high levels of anti-HDV immunoglobulin IgG and immunoglobulin IgM and confirmed by detection of HDV RNA in the serum. However, HDV diagnostics are not widely available and there is no standardization for HDV RNA assays which are used for monitoring response to antiviral therapy. Coming to HCV viral infection, incubation period is 2 to 26 weeks. The virus is detectable in plasma within days of exposure, often 1 to 4 weeks. Viremia peaks in the first 8 to 12 weeks of infection and then drops to undetectable level. In majority 50 to 85% it persists. 80% become chronically infected and at least 30% carriers develop chronic liver disease. 20% will develop cirrhosis and 1 to 5% will develop hepatocellular carcinoma. For the lab diagnosis of HCV infection, as HCV antibodies are not, only 90% of antibodies are detected in chronic patients. In acute infection, only 50 to 75% are detectable. So, HCV RNA detection by PCR is the most sensitive and gold standard technique for the diagnosis of HCV infection. HEV infection. Incubation period is 2 to 6 weeks. HEV RNA is detected in blood and stool 3 weeks after infection, with viremia lasting approximately 3 to 6 weeks and shedding of virus in stool for approximately 4 to 6 weeks. The first appearance of HEV RNA occurs shortly before the onset of symptoms. Around the time of clinical onset, biochemical markers become elevated and IgM antibodies appear first, followed soon by IgG antibodies. IgM antibodies are relatively short-lived, usually no longer than 3 to 4 months, but may persist up to a year. However, the IgG response is long-lasting. Before the elevation of the liver enzymes, the viral particles can be, for lab diagnosis, viral particles can be detected in stool, serum, by electron microscopy. Along with the elevation of the liver enzymes, the antibodies also start developing. There are various ELISA techniques for the detection of antibodies. IgM is detected after the exposure of infection to after 2 to 3 weeks, and it may disappear after 12 weeks. IgG also appears after the appearance of IgM 2 to 4 weeks and may persist for many years. And it indicates only presence of IgG antibody indicates either it is recovery or past infection. Thank you.
Thank you, Dr. Yamini ma'am, for the clear, splendid presentation on infectious hepatitis. I open the session for questions. Okay. Thank you all.